All right, everybody, welcome to the second session of the pulmonary function test standard practice. Our title for today is going to be the interpretation of spirometry and lung volumes. So after last session, I think most of you will have the basic knowledge of how to perform a correct spirometry technique. And we all agreed that performing a correct spirometry technique is crucial for having a reliable result. So you cannot interpret a spirometry unless it is actually reliable. فعرفنا what do you mean by reliable spirometry? We talked about the acceptability criteria and the repeatability or the reproducibility and all the instructions that should be given to the patient at the time of appointment when he come to the day of the test, the things that he or she should avoid, and the instructions that should be given to the patient and the coaching also. For today, inshallah, we will continue based on last week. That is now we will look to the interpretation of the results. Okay, for those who joined us for the first time, just a quick introduction about myself. My name is Hussam Mohammed Abdel Hamid. Graduated from Juba University. I have a master's in physiology, and my last achievement was the MD in respiratory medicine. Now I'm working in the respiratory care department in uh, Imam Abdurrahman bin Faisal University in Dammam. So inshallah, let's start our session. And since we are starting to interpret the pulmonary function test or the spirometry results, so this session will be filled with loads of graphs, figures, and numbers. So today we are going to take these figures, these numbers, and these graph, and at the end, all of them will make sense. So we'll make sense of all of these figures. بتكون مرت علينا كتير regarding the pulmonary function test results. So at the end of the day, you will never be intimidated again by them. So as we are proceeding through the session, you are going to be overwhelmed with a lot of figures, numbers, and graphs, like you are going to decipher them all. So it will be as easy as, and we'll make it as easy as possible, inshallah. So these are our contents for today, or our headlines. So first of all, it's in general, this session will be divided into 4 sections. The first section I'll be talking about the pulmonary function test report structure. يعني مما يتكون ال PFT report. المفروض الستاندرد PFT report يكون فيه شنو؟ وهنتكلم عن also the type of spirometric curves. What are the different types of curves? The second section will be the basic spirometric calculations. Now, luckily, this is the digital era. This is the era of the machine. So rarely now you need to do it manually. So like at the end, you should know how does the machine calculate these values. Nowadays, all the machines, the latest spirometry softwares, it automatically give you the results with the calculations. You don't need to calculate it manually. But for the sake of knowledge, and you should all of us should have the basic knowledge for this. So we'll talk about how do we manually do these basic spirometric calculations. Then we'll talk about the third section, which is the spirometry patterns. So we'll get to know the normal spirometry pattern regarding the curves that we are going to mention, and the abnormal patterns, how to differentiate between the different type of spirometry patterns, either normal or abnormal. And the last section will be the step, or will give you a stepwise approach, doing steps in how to interpret a pulmonary function test. Here, I'm going to concentrate on 2, the spirometry together with lung volumes. Yani we'll not talk about the rest of the PFTs. Inshallah, the next session will go beyond the spirometry and talk about the other advanced PFTs, that is the Delco, the Fino, the iOS. فهنا بس حنركز عن how to interpret لأنه this is most of the PFTs. It contain the spirometry values or spirometry measurements and the lung volume measurements. So at the last section, we will give a stepwise approach how to interpret the pulmonary function test. So the objectives of this session, by the end of this session, all the attendees should have the ability to differentiate between obstructive and restrictive disorders based on the PFT, and diseases that affect the lung versus those that affect related structures. So also the PFTs can give us an idea about, is the cause pulmonary or is it extra pulmonary? Also, another objective is to apply the standard pulmonary function test interpretation guidelines. So this is what we are going to be talking in the last section. And the third objective is to interpret the results according to the demographics of your patient. So let's start with the first section. That is, we will have a general look about the PFT report and the different type of spirometric curve. Now, this is the standard PFT report. It should be composed of number one, the patient demographic data. That is the name of the patient. Here it may include the name of the patient, age, height, gender, ethnicity, and here you may put the diagnosis. What is the differential diagnosis or the possible diagnosis? The weight, the body surface area. Also, it is important the smoking status. Is the patient a smoker or ex-smoker? Did he smoke before the test? Also, this should be noted because some PFT, especially for example the DELCO or the diffusion capacity, is really affected by the smoking status of the patient. So these are the first thing in the PFT report, that is the demographic data. The next part of the PFT is the flow volume curves of all acceptable trials. So it may be 1, 2, 3, they all should be in the report so that the interpreter or the physician should know the different trials by the patient. And this is the flow volume curve or flow volume loop. The other component of the PFT report is the volume time curve, برضو, of all acceptable trials. Sometimes some labs or some institution, they don't give all the curves or the flow volume loop or the flow volume curve. They give the best. لكن it is preferably من الأفضل من أحسن إنه it should include all the trials of the acceptable trials of the patient. So we have the first component of the PFT report is the demographic data. The second component is the flow volume curves. And the third component is the volume time curve. Next slide, what is the difference between the flow volume curve and the flow time curve. So they should be included. The third component is the numeric results. So زي ما ملاحظين the PFT report, it has figures or it has graphs and it also has numbers. So also there should be tables. These tables are the numeric results of all the volumes and the flows. So لو لاحظنا to these, it include, so this first section, this is the spirometry. So these numeric results, it includes spirometry. So all of these are spirometric measurements that we talked about last time. And the next also, it contains the lung volumes. It contains lung volumes. So this is the lung volume section. Also here, it contains the DELCO. So this, for example, the DELCO. Sometimes it may contain more. So like in the important is the spirometry, lung volumes, and the DELCO. طيب, on these columns هنلقى predicted lower limit of normal, LLN, is lower limit of normal. and this is the percent predicted. طبعا هنا هيكون في the actual اللي هي this is what the patient or the patient measured. يعني actual عندنا هنا column حق actual اللي هي this is the patient measurement. عندي ال predicted. طيب what is the predicted؟ ال predicted دي هنا قاصدين بيه the expected. That is depending on the age of the patient, the gender of the patient, his height, and his race. اللي دي اللي اتكلمنا عنه last time, these are the factors that affect the vital capacity. So the predicted value, this is the expected according to the patient age, gender, height, and ethnicity or race. This is the predicted. فكل اللي انا بعمله you should compare the actual يعني فعلا جات by the patient and the predicted according to his age, gender, height, and race. طيب في other guidelines اللي هي especially the American Thoracic Society guidelines the ATS دائما بيفضلوا the lower limit of normal. فبرضه ال lower limit of normal it is based on age, gender, height, and race. So if you remember last time or last session, the paper that is done by Prof. Umar Abdulaziz and Dr. Amir Ali Bashir, they actually did the predicted. The Americans, they usually do the lower limit of normal. Both of them, they can be applied. عشان نعرف إنه is my patient results, is it with the normal expected or not. طيب هنا this is the percent predicted. هنا دائما percent predicted, and you have been seeing this a lot, especially in exams and in MCQs questions. Like this patient had, for example, FEV1 60% predicted. طيب what do you mean by 60% predicted؟ كيف نحن نقدر نحسب ال percent predicted؟ Simply ال percent predicted عشان نحسب ال percent predicted it equals the actual, that is the measurement of the patient measurement divided by the predicted multiplied by 100. دي حتديني نسبة. This is known as the percent predicted. طيب فهي دائما اسهل انه انا اتكلم بالبرسنت بريدكتد rather اكثر من انه just predicted. دي لأنا طوالي بتربط لي انه is it high or low or is it normal لما انا اتكلم بالبرسنت predicted. So again we have the numeric results بتتكون من columns. These columns or ممكن يتكون من rows. Rows, these are the PFT tests. So it can be spirometry values, it can be lung volumes, it can be DELCO, it can be propagation test, whatever the tests that are being performed. These are for the rows. For the columns, it contains a column for the actual. That is the actual values that is measured by the patient. Then it should contain the predicted. قلنا the predicted, this is the expected value according to the age, gender, race, and height of the subject. يعني مفترض الشخص في عمر وفي gender وفي according to his gender, according to his height and race or ethnicity يكون his FEVC or FEV1 يكون كده. طيب قلنا بعد ذاك also بنحسب ال percent predicted. Now the percent predicted, how do you usually measure it? It is the actual that is measured by the patient divided by the predicted that is known. It is, for example, for the Sudanese, it is already known. There are tables for it. So the predicted, you can go to the paper and you can see it. So you can see any patient with an age according to his gender and according to his height بيديك رقم. This is the predicted. لما أقسم the actual of my patient divided by the predicted times 100 ده بيديني the percent predicted. طيب, so this contains, it may also, there can be also another column, and this column may contain the bronchodilator response. يعني أنا ممكن أضيف ثاني column هنا اللي هو البوست bronchodilator response. فإذا مثلا أنا اديت my patient bronchodilator، عندنا البري bronchodilator وعندنا البوست bronchodilator response. So another column can be added here that contains the spirometry after giving the patient a bronchodilator. Inshallah, we will talk about this next in the next session. That is how to interpret the bronchodilator response. So Now, just let me talk a little bit here about the predicted عشان to give you idea, especially for those who are going for the exams. لأنه a lot of questions may come in the exam فيها يكون في PFT. طيب, for the normal, that is FVC, قاعدة عامة. FVC أي حاجة يقول لك from 80 to 120%, this is normal. So FVC 80 to 120% of the predicted. يعني if a patient is having an FVC that is 80% لحد 120% of the predicted, this is considered normal. Less than 80%, this is low. So this is for the FVC. So FVC and FEV1 الاثنين ديل النورمال بتاعهم 80 to 120% of the predicted. طيب, this is for the spirometry. بالنسبة لللung volumes, the residual volume, the FRC, يعني the residual volume and the FRC, both they are from 75 to 120% predicted. The residual volume and FRC, the normal range of the percent predicted is from 75 to 120% predicted. The TLC, it is from 80 to 120% predicted. 80 to 120% predicted. بالنسبة للدلكو, it is from 60 to 120% predicted. So I hope these values would be clear. So this will give you an idea. So إذا بس عين للرقم FVC, FEV1 والTLC ديل كلهم من 80 ل 120% 100% و 120% predicted. أقل من كده less than 80, this is low. More than 120, this is high. That is why when we use the percent predicted بنستغنى عن the predicted and the actual. كده أنا already خلاص عرفتها إنه if for example my patient is having an FVC that is 50% predicted, معناتها إذا هو البريدكت بتاعه 4, so 50% معناته هو جايب 2 liters for example FVC. So أنا كده استغنيت إنه I don't need to know the measure or I don't need to predict it. So it just gave me an idea. So that's why mostly you look at the percent predicted. So I hope it is quite clear. So as general, القاعدة العامة إنه normal percent predicted من 80 ل 120. في small differences اللي هي في FRC وفي residual volume. They are 75 to 120% predicted. So this is regarding the percent predicted and the structure of the PFT report. So I hope this is clear. So again, the PFT report, it contains these 4 components. Number 1, the patient demographic data, which is important. So it can have the name of the patient or the ID according to the institute, definitely his age, his height. Last time عرفنا how you should do the proper measuring of the height. لازم, the height is important. حتى تكلمنا عنه there are a lot of methods to do the height. يعني no way you should skip this. Even if your patient is lying in a vegetative state in an ICU bed, you can do his height. So height is important. Now all of these numbers, they depend on the age, the height, the gender, and the race. These are the 3 important things. Others, optional, can have the differential diagnosis or what are the chief complaints that made this patient come to do to the pulmonary lab to do the PFT. Another thing that's also we mentioned that is important, that is the smoking status of the patient. And this is for the demographic data. The second components are the flow volume curve. Ideally, there should be all the acceptable trials by the patient regarding the flow volume curves and the volume time curves. And then the fourth component is the numeric results. قلنا عندنا rows, these rows, it can be spirometry, lung volumes, DELCO, whatever other test that is being done, bronchopropagation test, and there are columns. The columns contain the numbers that is of the actual test of the patient, then the predicted, قلنا the predicted is the expected according to the patient age, gender, height and race. تكلمنا عن lower limit of normal. So أي حاجة below this lower limit of normal considered low. وتكلمنا عن the percent predicted. And how do we measure the percent predicted? قلنا by actual, the measured divided by the predicted times 100. It will give me the percent predicted. Other columns that can be added that are for the the pre and the post bronchodilator response. One, we talked about how to know the normals, that is for the different measurement. فقلنا القاعدة العامة, the general idea or the general rule, it is from 80 to 120% predicted. Just slight difference for the TLC, for the FRC, that is the function residual capacity and the residual volume, from 75 to 120%. So less than 80% is considered low, more than that is considered high. So this is as far as the PFT structure, report structure is of concern. Now moving on to the next part, that is the curves. So there are three general curves that you will face in any PFT report. The first one is the classical one, that is the spirogram, which is the volume. It is the volume time curve. It is the volume time curve. So actually it plots the volume against time. From this curve, usually we measure two things. We measure the FEV1 and we measure the FVC. From the volume time curve أنا بقدر أحسب أطلع منه importantly two. The FEV1, that is the forced expiratory volume in the first second, and the FVC, that is the forced vital capacity. I will tell you how we do it in the next section. The second type of curve is the flow volume curve, and this plots flow against volume. هنا عندي volume against time. هنا ده flow against volume. This is flow against volume. وده بيكون شكله كده. From this, mostly, usually we can measure the FEF25. That is the forced expiratory flow. 25 اللي هي when the expiration is 25%. This is FEF50 when it is about 50%, and FEF75 when it is about 75%. An average of these بنسميه the forced expiratory flow 25 to 75%. So this is the second curve known as the flow volume curve. This is volume time curve. And the third is the flow volume loop. This one is flow volume curve, نصه flow volume curve. لما يكون مكمل لتحت بيبقى اسمه flow volume loop. طيب flow volume loop لو ملاحظين له فيه upper part وفيه lower part. دائما upper part, this is the expiration. The upper part, this is expiration. Upper part is expiration. So usually, if you remember last time تكلمنا عن maneuver, when you ask a patient to take a deep breath in as maximum as you can until all your lungs are filled. So we start from this point. We start from total lung capacity. The patient start to exhale as hard and as fast and as he can. عشان كده حيكون عندي a rapid peak to the flow. So this peak is called the peak expiratory flow. لازم تكون rapid. It should be rapid, a straight line like this. لأنه we instruct the patient to exhale as hard and as fast as he can. So the patient will start to exhale. He will reach to the maximum. This is called the peak expiratory flow. بعد شوية flow will start to decline. So this is a linear decline. إذا أنا عندي a rapid rise. لازم يكون عندي rapid rise from TLC followed by a linear decline. So this linear decline or linear fall, you ask the patient to exhale, exhale, exhale until I need you to squeeze all the air from your lungs. اللي هنحصل يا نقطة the residual volume. So we end with the residual volume. ده كده يا دوب اداني the maximal expiratory flow volume curve. طيب انا لو عايز اعمل اللوب, you should continue instructing the patient from this point, that is once he reach residual volume, then you ask him to inspire hardly back to TLC. فهيديني the second part of the curve or the loop, that is the inspiratory curve. والinspiratory curve it goes from right to left. هنا this one الاكسبيريشن بيمشي from left to right. يعني دايما في الكيرف it goes like this, left to right, then ask the patient to inhale back, then it will go right to left. So إذا الآن للعكس. Now we'll go from the residual volume, because now you are going to ask your patient to inhale rapidly back to the maximum. That is the maximal inspiration. This is maximal inspiration. So here also we'll have the peak inspiratory flow. Now this horizontal line that is between the residual volume and the TLC, this is the vital capacity or the forced vital capacity. At the midpoint, في النقطة دي, this midpoint is known as the forced expiratory flow at 50%. اللي هي النقطة دي. This is called the forced expiratory flow, and this one is called the forced this is called the forced inspiratory flow. And these two are important. I will explain them later to determine is there any upper airway obstruction. بنعاين like this, the FEF and the FIF50. That is the forced expiratory flow 50% and the forced inspiratory flow at 50%. So usually this ratio, that is the forced expiratory flow 50 to forced inspiratory flow 50, is normally less than 1. So I want you to keep this piece of information. The ratio of FEF 50 to FIF 50 is less than 1. What is FEF 50? This is in the flow at the midpoint of the flow. At the midpoint of the flow. At this midpoint of the flow, this is known as the forced expiratory flow 50%. بنفس الطريقة at the midpoint of inspiratory flow, indeed the forced inspiratory flow 50%. The ratio between these two, it should be less than 1. So as I told you, please keep this piece of information in mind when we come later to talk about the upper airway obstruction, because you can differentiate between is it a fixed, a variable, depending on, or is it intrathoracic, is it extrathoracic, by looking at this ratio. So this is the third curve, or this is the third figure in the spirometry, that is the flow volume loop. Flow volume loop. Just a quick reminder here, the flow is 2 liter per second per unit distance. Yeah, usually it is 2, 4, 6, 8. And similarly, the below is the pressure. So now these are the characteristics of the flow volume and the loops that makes it acceptable or unacceptable. يعني نفس الكرايتيريا الآن I talked about it in the previous slide. إنه number 1 لازم يكون عندي a rapid increase or rapid rise اللي from the TLC هنا. This is from TLC. So there should be an instantaneous start of exhalation. They should know, the patient should not hesitate. ما المفروض يتردد طوالي. I need you to blow hard as fast as you can. عشان كده there should be no hesitation اللي دي بنسميها the good start. Then there should be a rapid rise اللي هي number 2. There should be a rapid rise to the peak. البيك ما لازم تكون flat. It should be a peak. and then it should be followed by a smooth decline or a linear fall back to the zero, which is the residual volume, followed by 6 a smooth continuous inhalation back to TLC. فلازم اللوب عشان كده هو اللوب المفروض يكون it should be اللي هي not like this one هنا as you can see this is incomplete loop يعني لازم the patient should it should he should complete the loop. فthese are examples of unacceptable spirometry loops. أول حاجة number one اللي هي ما عندنا rapid this is slow start. The patient hesitated. Here, number one. Number two, there is no rapid rise. Number three, there is a flat peak. Four, any kind of interruption, jagged ends. This is the common cause of cough during the fall. دي ما دايرين jagged ends. طيب. Number five, اللي لو ملاحظين لها هنا, look at this. Let me. So look at this. This is a rapid decline to the zero. A rapid decline to the zero. It should not be rapid. Usually, for example, if you decline, بعد شوية بتلقى نازل like this. This is a rapid decline to zero. Also, it is an unacceptable. This is an unacceptable due to, for example, glottic closure. So these are the important characteristics of the flow volume loop and what makes it unacceptable. So I hope so far these are clear. Now some figures it can add the SVC. In most spirometry بتلقوا curve like this. This is the slow vital capacity اللي اتكلمنا عنهم previously. ديل كانوا the forced vital capacity. Now this is the slow vital capacity volume time curve. This is the tidal volume هنا. This is the tidal volume. You let the patient breathe in normally, in and out, then ask him to inhale up to the maximum and then exhale, squeeze all the air out and back, then continue to inhale. فقلنا فائدة ال SVC إنه from this the device can measure the tidal volume, it can measure the inspiratory reserve volume, expiratory reserve volume, and the vital capacity. All of these can be measured from the SVC maneuver. You'll find a lot of spirometers will have this curve. So this is the SVC volume versus time curve. So this is the end of the first section, that is the PFT report structure and the curve. So as I told you, if anybody's, I will check the Q&A section if there is any question. So if you have any question regarding this first section, you can gladly pop up your questions before we proceed to the next section. Okay, so there is no question so far, and I hope I'm going with the steady pace, and all things are clear for you. Now let's move on to the next section of our session, that is the basic spirometric calculation. Now, as I told you, nowadays it is not a requirement to do the calculation manually, because already it is done by the machine. So now let's talk about how to determine the FEV1 values from the FVC maneuver or from the volume time curve. So several spirometric values can be calculated manually by hand from mechanically produced volume time spirograms. But before doing that, there are three things that you should always make sure of. That is, number one, the subject produced acceptable trials. So the trials should be acceptable. This is what we talked about last time. إنه أصلاً قلنا قبل ما نبدأ to interpret the results, we should make sure that the patient did acceptable or he performed a good maneuver عشان في النهاية نطلع ب acceptable results or reliable results. So should make sure that the trials are acceptable. يعني شنو أنا قاصد the trials are acceptable, they should be free from errors. What are these errors? هنتكلم عنها in the next section. That is are the pitfall. يعني like cough, early termination, glottic closure, mouthpiece obstruction. All of these are errors that hinders the trial to be acceptable. So number one, make sure that the trials are acceptable. That is, the tracings are free from errors. Second thing, you should check for the repeatability. Also اتكلمنا عنها last time, the repeatability. So you should check for the repeatability between the two largest FVC. طبعا between the two largest acceptable trials. فأول خطوة أنا تكون أتأكد إنه my trials are acceptable. Then are they repeatable between the two largest؟ بعين the two largest are they repeatable or not? Are they repeatable or not? If they are repeatable, then you should calculate from the largest. يعني we don't get the average, we calculate from the largest. Then before you determine the FEV1 from the volume time curve, these three things you should do. First, number one, اللي هي after the subject, make sure that the subject produced 3 acceptable tracings. اتكلمنا عن last time قلنا at least we need 3 acceptable tracings or 3 acceptable trials that are free from errors. These errors such as if the patient coughed, early terminated, glottic closure هنتكلم عنهم in a while. Number two, are they repeatable? That is, you look at the two largest acceptable tracings يعني بنعاين ال FVC of the two largest acceptable. Are they repeatable or not? هوريكم how to calculate the repeatability. Are they repeatable or not? And then from the largest you calculate your spirometric values. Then when we calculate the spirometric values from the largest. So this is our volume time curve. So simply now let's calculate the FEV1. Simply the FEV1 اللي هي نفس الاكسبتابيلتي كرايتيريا اتكلمنا عنها انه لازم انا يكون عندي good start of test like this one. So this is a good start of test. فهنا this is the time. So the moment when the patient start to exhale, this is time 0. So the second after it is going to be 1 second. So from this 1 second برسم انا خط النقطة اللي بيتقاطع فيها الخط where this line is going to cross بشوفه هنا what is the volume. Say here it is 4.3. So my FEV1 here is 4.3. This is for the calculation of the FEV1. So FEV1 بعينا لل 1 second, draw a straight line that crosses with the patient curve. This طوالا هشوفها بتعادل لي أي volume. That is why it's called volume time curve. So this is for the FEV1. For the FVC, you look for the plateau. So this is the plateau. ده هنا البلاتو. كيف أنا أحدد البلاتو؟ إنه there should not be an increase. يعني البلاتو كلنا عارفين plateau. طيب لكن أنا أحدده كيف إنه this is the point of the plateau اللي there should not be an increase or the plateau should be with less than 50 ml of air being exhaled. Less than 50 ml of air is being exhaled. كده أنا بقول إنه the patient has reached the plateau. As I told you last time إنه one of the criteria الآن اتسحبت إنه it should be for 6 minutes 6 seconds لكن الآن دي is out of the latest guideline. إنه المفروض at least the patient should exhale for 6 seconds. لكن you know there are quite normal persons or subject they can exhale they can reach the plateau within 3 to 5 seconds with a very acceptable and repeatable trial. عشان كده حتة ال6 ثواني اتشالت. ف this is the idea. So how do you calculate or how do you know the FVC? You look at the plateau اللي دي كده plateau. انا كيف بحدد انه انا حصلت البلاتو؟ انه الخط يكون مستقيم، بمعنى اخر ما يكون في زياده باكثر من 50 مل or 0.5 liters. So this is the point of plateau. فحدد انه this is the point of plateau، برضو برسم خط مستقيم that corresponds with the volume. So هنا بيبقى لي مثلا my FVC is going to be 4 point say for example 8. كده الآن أنا حسبت دي FEV1 وحسبت ال FVC from the curve. Now luckily زي ما قلت لكم all of these are done by the machine. طوالي بيديك إنه والله FEV1 كده ال FVC كده والريشيو. So the ratio اللي هي نتيجة قسمة الاثنين دول على بعض that is the FEV1 divided by the FVC. This will give me the ratio. So the ratio can be calculated dividing the FEV1 by the FVC. So it is simple as that. So this is how to manually calculate or measure the FEV1 and the FVC. Now, as I told you that FEV1 is commonly used as an index for airflow. FEV1 is an index of airflow, whereas FVC is an index of the lung parenchyma. FEV1 is an index for airflow. FVC is an index for the parenchyma. That is why patients who are having obstructive lung disease, COPD, asthma, so they are having troubles in the airflow. This will affect the FEV1 mainly. So their FEV1 is going to decrease. Those patients, they don't have problem in the parenchyma, so their FVC might be normal or it might be even high. So mathematically في الرياضيات لو البسط قل والمقام ظل ثابت أو even زاد بيحصل شنو النتيجة؟ is going to decrease. That is why obstructive lung disease will decrease the FEV1 FVC ratio. عشان كده عشان obstructive patients the FEV1 is more affected والFEV1 قاعدة فوق في البسط. So إذا قل البسط مقارنة بالمقام اللي هو يا ثابت يا زاد النتيجة حتكون بسيطة. That is why the obstructive lung disease usually it will have low ratio. والعكس patient with restrictive. Now this patient with restrictive lung disease it affects the parenchyma of the lung. So their FVC is going to drop. At the same time their FEV1 is going to drop. Here the FEV1 in the restrictive lung disease, it does not drop because of problem in the airflow, but because of the decrease in the total cross-sectional area. لأنه restrictive lung disease بتساوي small lungs. So small lungs بالتالي the airflow is going to decrease. But because they decrease, the decrease is proportional. يعني النقصان بالتناسب. The FVC will drop, FEV1 will drop. بالتالي the ratio will remain constant, normal or slightly increase. So that is why restrictive lung disease will lead to a normal or a slightly higher ratio. So I hope you know this would be now clear. You know how all of us know how to differentiate obstructive from restrictive. In obstructive, low ratio, restrictive, high or normal ratio. الآن إنه ليه؟ Because the FEV1 is a index or indicator to the airflow, whereas the FVC is an indicator to the parenchyma. Just one last point regarding this FEV6. FEV6. This is usually it is a surrogate, بديل, instead of using the FVC in patient with obstructive lung disease, because patient with obstructive lung disease usually they don't reach the plateau in 6 seconds. They need more time to reach the plateau. Sometimes ما بكون عندي plateau. Usually this patient will fail to reach a plateau لأنه the airways are narrow and they will still blow and blow and blow, still they cannot reach the plateau. Sometimes the FEV6 is used as a surrogate for the FVC in patient with airway obstruction. So this is as far as the calculation of the FEV1 and the FVC and ratio and the relation of these to obstructive and restrictive lung disease. So precise timing and acceptable start of test are required to determine FEV1 values accurately, and already I've mentioned this. Now, this is an exercise. I will give you 30 seconds with your own. أي شخص لوحده determine the FVC for curve A, curve B, and curve C. And then comment on the repeatability or the reproducibility. So I'll give you 30 seconds. Check these curve, determine just the FVC. Just the FVC. Determine the FVC, how much is it for A, B, C, and comment on the repeatability. Okay, so now what is the FVC for A? As I told you, you look at the point where the curve now is being the mostly flat. So this is curve A. Let me focus it more. So this is curve A. هنشوف الحتة فيها it is being more flat. So this one at this point. So usually if we move to it هنلقى it is about 3. This is 3.1, 0.2, 0.3, 0.4, 0.5 and 5. طيب this is a piece of note I would like you to share with you انه لو هتلاحظوا انه most of the numeric values بتكون 2 decimal. يعني مثلا 3.55. So A is actually 3.55 liters. So A is اللي هي من النقطة دي لو جينا حسبناه هنلقى إن 3.5 وماخذ شوية قبل ال 0.6. So it is 3.5 liters. This is for A. B, if we look at it also هنلقى إنه the curve اللي at this point. So if we look at it, so it's going to be about 3.30 or 3.33 liters or 3.1. طبعا definitely here manual is not going to be as accurate as the machine. بس I hope you get the idea. So C, this is C. So also we look at the curve where it is being reached the plateau. So at this point it is 3.25 or 3.226, say for example. So I hope the idea كده تكون is much clearer. So this is the FVC for curve A, B, C. Now the repeatability. هل أنا بقدر أقول إنه these trials are repeatable? So how do you know the repeatability? The repeatability, you look at the two largest and then you look to the difference. طيب, as I told you before, the repeatability criteria actually have been changed over the last 20 years. يعني a piece of information. The first guy, or for example, one of the guidelines by the ATS in the year 1978 كانت repeatability 100 ml. الفرق بين the two largest ما يكون أكثر ب 100 ml. جاء العام 19 in their next review in 1994 بقت 200 ml. repeatability between the 2 إنها ما تعدي 200 ml. And as I told you, in the recent 2020, we get 150 ml or not more than 5%, whichever is greatest. So this is now we'll talk with, يعني we'll deal with the latest guidelines. إنه the repeatability عشان أنا أحدد إنه the trials are repeatable, they should not be more than 150. Now the other question طبعا it's already answered إنه are these tests acceptable? Yes, they are acceptable. So are these tests repeatable? So we look at the largest. اللي هي the largest is A and the second one is B. فهتبقى عندي 3.55 minus 3. Say for example 333. ده هتديني ب 5533 ل 0.22 يعني 220 ml. 220 ml. So this is greater than the recommended or the latest guidelines. So this is definitely not repeatable. إذا أنا بقدر أقول إنه والله A, B, C they are acceptable لأنه they are free of error. عندي good start وعندي plateau has reached ما في أي error. So these tests are acceptable but they are not reproducible or they are not repeatable. لأنه the difference between the two largest is more than 150 ml. طيب لو عايز احسبها بالنسبه كيف بنحسب النسبه؟ القانون بتاع النسبه the percent repeatability هو بيساوي the best FVC اللي هي the largest one minus the second best divided by the best times 100. ده لو انا عايز احسب النسبه. ما هو عندنا خيارين يا اما 150 ml او 5% انه الفرق ما يكون ب more than 5%. طيب لو جينا نطبق الكلام ده على our example البيست FVC already جبناها 3.55 minus السكند بيست اللي هي 3.33 الفرق بيناتهم 0.22. اذا قسمناه على 3.55 times 100 and I already did the calculation هتجيني 6%. النسبة 6% also greater than the recommended. إذن again these اللي هي curve or these trials they are acceptable. هم yes they are acceptable but they are not repeatable. They are not repeatable. وعرفنا ليه they are not repeatable لأنه the difference between the two largest FVC is greater than 150 ml or even more than 5%. So I hope you know the all things here is clear. Now this is an exercise to measure the FEV1. So what do you think? How much is going to be the FEV1? So it is easy. 10 seconds. Look at the screen. So this is our first second. This is our first second. Now look at here where this is the straight line where it is going to intersect with our curve. So this is the intersection of our curve. So this is 2.90, 2.91 or لازم يكون قلنا 2 decimal. So my FEV1 is 2.90. How much is FVC? Now let's look at the FVC. So this is our curve. Here, this is the point. Here, this is the area of the plateau. So here it is 3. So it's going to be my FVC is 3.55. What is the ratio? هقسم الاثنين دول على بعض. الراتيو هتجيني 81%. And this is how a normal curve looks like. So 81% is normal. So this is a normal volume time curve. Now here I just want to talk about an important thing known as the extrapolated volume. دائما في الأجهزة بتلقوا مكتوب لكم VEXT. Always check this. V volume XEXT extrapolated. This usually it will determine if the patient hesitated or not. I need a test like that looks like this. قلنا لازم يكون عندي good start. That is good start, not like this one. This usually is going to affect the FEV1. فsometimes a device بيحسب لك from the extra plotted volume. According to the guidelines انه the extra plotted volume عشان يديني accurate FEV1 it should not exceed or it should not be greater than 150 ml or uh, or 5% or 5% of the total FVC. This is the extra plotted volume. There is manual calculation that can be done. يعني في طريقة manual لكن I will not go into it. يعني there is a manual way that you can measure or calculate the extra plotted volume. اللي like this one. دي هنا extra plotted. This is the extra plotted volume. فهنلاحظ هنا إنه this extra plotted volume 0.136 which is less than 150. So this is an acceptable result. But this one is not. لأن the extra plotted volume is more than 150. So the extra plotted volume usually is going to affect the reading of the FEV1. So what's the cause of a large extra plotted volume is a hesitancy. You know, the patient hesitated before giving his best. لأنه أنا عايز the patient to give his best from the start. يعني blow as hard and as fast as you can. This usually should be done from the start. Okay, another exercise. Now, can you look at this curve and then measure the FVC, FEV1 and the ratio? So in the same way, FVC, هنشوف where my curve is reached the plateau and there is no increase in the volume by more than by more than 50 ml. So this is the max point at this area. So it will equal to 2.25, 2.2 for again, it should be 2 decimal, 2.25. FEV1, so this is the first second. هنا طبعا عندي a slight extra plotted volume. لو ملاحظين شكل الكيرف it is sigmoid. Usually الكيرف أنا ما دايره sigmoid. It should not be sigmoid like this. It should be an abrupt start from the start. عشان كده هنا usually the device is we are going to calculate it after the extra flotation فبيجيني by 1.42 and the ratio will be 63%. All these calculation I've done it before. So this is an example of an obstructive curve. An obstructive curve and in the ratio is less than 70%. So I hope all things are clear now. You know how to calculate or determine the FE1, the FVC, and the ratio. And again, these manual things or manual calculations are no more done. Already it is measured by the new software. طوال بديك the results. So now after we have finished determining the FEV1 and FVC, now let's look at some of the spirometry pitfalls. That means what is the problem or error اللي انا قبل قلت انا عشان التست بتاعي لازم يكون acceptable. The test should be acceptable بمعنى انه يكون free of these errors. يكون free of errors. What are these errors and how to identify them and what are the effect or the implication of these errors on my result and how to solve them. So here there are a lot of pitfalls like I will talk about the common. فهتكلم من 4 جوانب. In what is the problem? How can you identify it? What is the effect of this problem on the results and how to solve it? Now the commonest problem, you will get faced a lot by it is submaximal inhalation او ما يعرف به بنقول عليه دي poor effort. The poor effort. زي ما قلنا أول مرة إنه spirometry is effort dependent. The patient should give his best. For sometimes the patient does not give his best for many reasons. For one of these reasons is improper coaching by the by the person who is doing the spirometry. So this is one of the common spirometry pitfalls, that is poor effort or submaximal inhalation. So these are two examples. The green one is an example of a good effort. The red ones are the example of the error. So our error is the poor effort. Now, as you can clearly see that the poor effort, it affects the FEV1 mainly. Sorry, it affects the FVC. Sorry, it affects the FVC. So you'll find curves like this with a gap. دائما you do the trials, you'll هتلقى there are gaps. يعني normally they should all be identical to each other. يعني يكونوا قريبات لبعض. لكن poor effort there is a gap. So a submaximal inhalation, usually this causes underreporting of the two spirometry, and the patient did not give his best. Usually, how to identify it? The lack of full inspiration, the patient did not take full inspiration, بالتالي he will not reach the FVC. عشان كده the poor effort or submaximal effort, it will affect the FVC. It will affect the FVC. So simply how can you know it? A layer like this, you will find gaps between the ending point of the multiple flow volume curve. You will find these gaps. So this usually indicate poor poor effort. So this actually قلنا what انا هتكلم عن من ثلاثه جوانب انه what is the error? The error is a poor effort. the identification, how do I identify it? انه بكون عندي multiple اللي هي curve like this with gaps at the end points, gaps at the end points. And what is the test result implication? They will falsely reduce the FVC. They will falsely reduce the FVC, and this will be misinterpreted as restrictive. ودي بتواجهنا كتير in our web. إنه most of the results بتجيك restrictive. So actually it is not restrictive, it is poor effort. And the patient did not inhale to the maximum, either due to, most commonly due to improper coaching. So always make sure that you coach the patient well. I need you to inhale, I need you to fill all the air, I need you to fill your lungs with the air as much as you can. So this is going to be the solution. Coach the subject to fill their lungs. You take the deepest breath that you possibly can. I need you to take the deepest breath that you possibly can. So this is the solution. And indeed, what is the error? Is the poor effort or the submaximal effort. And this is one of the frequent and serious problems that occur in spirometry testing. You will see it a lot. So how can you identify it? You will have these trials of the patient, you will find these gaps. So there is, because of the lack of full inspiration, is seen as gap between the FVC plateaus on multiple volume time curve. So you will see this space. Usually لو ملاحظين هنا, it does not affect the FEV1. But the patient did not take the full or the deepest inspiration or inhalation, so this will affect the FVC. زي ما قلنا, what is the implication of this? This will falsely reduce the FVC, بالتالي هيديني a falsely restrictive picture. How can I solve this? By coaching the patient to fill their lungs, taking the deepest possible breath they can. So this is the first spirometry pitfall or the first spirometry error. The next اللي اتكلمت عنه الآن is the extrapolated volume. دايما في الأجهزة بتلقوه VXT. Look at it. Now, from these two, this one 0.12 less than 0.15 أو أقل من 150 مل. So this is good effort. ما زي ده. So the effect of an excessive extrapolated volume. Usually excessive extrapolated volume indicates hesitancy. It indicates hesitancy. The patient hesitated. He did not start abruptly. So usually the curve is more of a sigmoid like this. The curve is more of sigmoid. So the effect of an excessive extra plotted volume, it will affect the FEV1 now. Now look at the FVC. The FVC is quite good, but the problem is with the FEV1. The problem is with the FEV1. So what is the problem? Excessive extra plotted volume. It indicates hesitancy. It indicates poor start. نحن لازم قلنا يكون عندي good start of test. How can I identify it? So usually لأن دايما hesitation بيكون early. So the patient will hesitate first and then he will start to blow until reaching his FVC. عشان كده the FVC is not affected. إنما the affected is the FEV1. It affects the FEV1. So it can elevate or decrease my FEV1, but this will affect the ratio. So how can you solve such a problem? Also by coaching. So you coach the patient or you coach the subject to blast faster or immediately. I don't want you to hesitate. Please blow as fast and as immediate as you can without any hesitation. If some patient they start to hesitate, يبدأ بالراحة and then he will reach his maximum. عشان كده هو بحصل له ال FVC but the start was poor. فده كله هيزيد له extra plotted volume. For also this is a common pitfall of spirometry. Now you know what is the error. How can you identify it? Like this in this error by this sigmoid shape. And what is the implication? It can decrease or increase the FEV1, but this will affect the ratio. And how to correct it or how to solve it? By coaching the patient to start immediately or to blast faster without any hesitation. The third also common pitfall, also common, you will see it a lot, is cough. Is when the patient start to cough during his exhalation. You will see this a lot. Once the patient start to cough. So what is the error? Is cough in the first second. So this usually will not affect the FVC. فهي دائما أي حاجة happens early will affect the FEV1. اي حاجه will happen late will affect the FVC. عشان كده قبل اتكلمنا عن البور effort لانه the patient will not take the deepest breath. He will blow will have a good start لكن he will not reach he will not terminate well. عشان كده the FVC will be affected في الاكزامبل الاول. In the second two examples اللي مسكناهم extra plotted volume والكف لانه they happen early بالتالي they are going to affect the FEV1. So the error is coughing in the first second. Usually this will affect the FEV1 measurement. How about coughing in the second? Usually coughing in the second it's going now to affect the FVC. So how can you identify this? By seeing a jagged end. You will see a jag here واضحة هنا in the flow volume curve واضحة هنا. Usually in the flow volume curve اللي هي دي. This is known as a jagged end. This is اللي هي is seen as a jagged interruption. اللي هي jagged interruption انه الفلو the linear قلنا smooth fall اللي هي المفروض يكون زي اللون الاخضر. بعد شوي you will find a dipping like this. This is a jagged interruption. So this usually اللي هي indicate cough. طبعا it will be multiple jagged لأنه the patient will cough more than once for example. So this is a cough. طبعا definitely the solution it is hard to prevent cough. لكن one of the solutions that can be given you need to moisture the air the throat. That is why sometimes you may give the patient a cup of water to minimize the irritation. لكن في النهاية the cough is out of your hand. You cannot prevent the patient, or even the patient cannot prevent himself from coughing. لكن try to do the maximum. So you can give the patient, for example, a cup of water, trying to soothe the throat to decrease the irritation. So this is the third spirometry pitfall, that is coughing. So the cough might falsely reduce or elevate the FEV1. This depends on the strength of the cough. This depends on the strength of the cuff. طيب بالتالي affecting my FEV, the FEV1 will have effects on the ratio. Another common error, that is early termination. In when the patient will take his deep breath and he will blow, لكنه he will not continue اللي هو up to the, he will not continue. يعني if you remember the maneuver, ask the patient to inhale to the maximum, then blow as hard and as fast as you can, and then continue to blow until you squeeze all the air out of your lungs. يلا الجزء الاخير ده ما في. He does not continue to blow, he will stop. فدي اسمها early termination. فواضح جدا early termination it is going to affect the FVC. It's going to affect the FVC. ففي ال volume time curve بتلقى الكيرف اتقطع هنا، ما it will not continue. وفي ال flow volume curve بيكون عندنا abrupt decline to the zero، اللي هي يعني لو لاحظين هنا ده it goes smooth back to the zero. ففي الابربت بيكون ماشي declining وفجأة ينزل. This is an abrupt decline to zero. ده في ال flow volume curve. وهنا بتكون سهلة في الفلو في ال volume time curve. So this is how to identify. So it is most clearly طبعا seen as a lack of plateau. There is a lack of the plateau. There is no plateau in the volume time curve. بالنسبة قلنا للفلو volume there is a rapid decline to the zero. يعني بيحصل لي rapid drop to the zero. What is the effect? قلنا it will falsely reduce the FVC. The FVC will be falsely reduced. بالتالي حيديني misinterpreted as restrictive. زيها وزي poor effort قبل. This will be misinterpreted as restrictive. اللي how to solve this problem also by coaching. You need to coach the subject to keep blowing until he told to stop. Keep going, keep going, keep going, keep going, and you instruct him to stop. So this is early termination. So I've give you here. There are a lot of pitfalls. Like in I've just I want to talk about these here. The common, the poor effort. It is one of the frequent and serious pitfalls. You know, the patient does not give his best, or mistakenly they are given as restrictive results. تكلمنا عن the early termination وعن الكف والlarge extrapolated volume due to hesitancy. Now, here we have an exercise for you. So tell me whether of the following PFTs or spirometry are acceptable or not. If not, why? So this is number 1. So you can write it in the chat if you would like. So this is the first curve. Is it acceptable or not? I need your contribution now to see. So this curve, can you consider it acceptable or not? Okay, imagine not. Anybody else? Okay, Annie, what do you think? Okay, why it is not acceptable? Yes, you are right. This curve is not acceptable. So why it is not acceptable? Why it is not acceptable? No, okay, reproducibility حاجة والacceptability حاجة. Here, yes, they are not reproducible لأنه there are variable efforts in the maneuver. لكن why is the curve not acceptable? يا واحد actually is not acceptable. No. As you can see, yes, extrapolated volume فيها to curve. Extrapolated volume is in the extrapolated volume is in C. والما acceptable, yes, it is A. So why A not acceptable? لاحظوا الحتة دي. This is a jagged interruption. So هنا the patient coughed. So this is cough in the first second. So these, yes, they are not reproducible. السي لو ملاحظين لها هنا هي في سلايد اكسترا بلوتد فوليوم، لكن هنا بنركز على لاحظوا A there is a jagged end so the patient coughed. Okay, for this are they acceptable or not? And if not, why? Okay, Dr. Marwan. Yes, they are not acceptable. So why they are not acceptable? Okay, Dr. Mahmoud. Yes, they are not acceptable. Yes, extra plotted volume in which one? Yes, there is extra plotation in curve C, as you can see it here. Now, what is the other reason? في حاجة تانية is very clear. واضحة جدا. Is there a plateau? هل نحن وصلنا plateau؟ لاحظوا دي كم second؟ 10 seconds. Did the patient reach the plateau؟ لو ملاحظين حتلاقوا الكيرف they are still going up. يعني still the curves are all going up. So this is failure to reach the plateau. So failure of plateau. So this is failure of plateau لكل الكيرفز. وعندنا زي ما قلنا C اللي هي extra plotted. Okay, this one acceptable or not? Okay, Dr. Mahmoud. Yes, they are not acceptable. Why? Okay, Dr. Marwan. Yes, they are not acceptable. Why they are not acceptable? Yes, very good. Also failure of plateau. الآن ده عكس ذاك. So هنا the plateau is declining. So this usually indicate a leak. This is indicate a leak. So also failure of plateau, this indicate a leak either from the mouthpiece or is a كان from the wires or so this is yes, very good, Dr. Mazin. This indicates a leak. And this one acceptable or not? This one, number 4. Okay, Dr. Mahmoud. Why? Why do you think it is not acceptable? برضو حاجة واضحة جدا. Look down here. Do they start from baseline? So they do not start from the baseline. لاحظوا هنا usually they should start from the baseline. So the 3 curve they have baseline error. No, this is not extra plotted. هنا دي بادين من they are not starting from the baseline. if you want to calculate such a thing معناتها هنحسب دي how much is this volume اللي هي 1 2 3 هنطرح 0.3 من اي واحده من الاف في سي والاف في 1 انا هطرح منها 0.3 لتر اللي هي this is because of the baseline. And the last one acceptable or not? Okay, why not? Okay, yes, we can look here. Our plateau does not reach. Okay, okay, thank you for your precious contribution. Now let's continue on the third section. That is the pattern. So far, let me check the Q&A. There is no questions for the previous. Okay, now let's talk about the patterns. Now, generally, there are 3 patterns for spirometry. Ladies, either obstructive, restrictive, or mixed. So this is the volume, time, and this is the flow volume. So this is the two. The one with the solid, this is the normal, and the one with the dotted, this is the abnormal. So this is the normal, this is the abnormal, and you can clearly look at the curve. So let's look at the volume time. So the volume time, which one is more affected هنا early the FEV1. عشان كده قلنا في الأوبستراكتيف إنه the FEV1 will drop. طيب هي أصلا الفكرة بتاعت ال FEV1 شنو؟ إنه in the normal subject usually you should exhale from 70 to 80% of the air in the first second. في الشخص الطبيعي اللي عنده normal airways you should exhale 70 to 80% of your vital capacity in the first second. So if you are having any obstruction or narrowing, this will hinder this percent. عشان كده ال FEV1 in obstructive lung disease is going to decrease. عشان كده لو ملاحظين لها compared to the normal it will decrease. لكن look at the FVC انه the FVC at the end he will reach the plateau. لكن حصل البلاتو 200 more than 6 seconds. More than 6 seconds. طيب in the flow volume curve, this is usually looked at as scooped end. This اللي هي الحركه دي عندي لو متذكرين قبل اتكلمت عن الكيف انه لازم يكون عندي a linear decline. هنا ده بكون scooped. So this is scooped اللي هي end. This indicate obstruction. This is a scooped end. So this is the obstructive pattern. Already اتكلمنا عن النمبرز انه ال FVC في الobstructive بتكون normal or high. ال FEV1 is the one that is going to drop. عشان كده الريشيو is going to drop. Now the next one is the restrictive pattern. Now باختصار a restrictive pattern is a miniature of the normal curve. يعني ما زي الobstructive ما فيه scooped end وما فيه the FEV1 will not reach. لا, it is a miniature of the normal curve. So if we look at these two, لو عينا هنا, that is the volume time. Look at the two, they are identical, but the restrictive one is a mini of the curve. لأنه the patient is the patient volume lungs is small. ونفس الطريقة if you look هنا at the flow volume. So at the flow volume also it is a miniature of the normal curve. We already اتكلمنا قلنا في restrictive FEV1 will decrease, FVC will decrease proportionally, thus the ratio will be either normal or slightly increased. ده بالنسبة للrestrictive. طيب عندي the third pattern is the mixed pattern اللي هو ده ماخذ من الاثنين. That is the mixed pattern. So look at this, look at the volume time اللي هو هنا عن لاحظين the FEV1 is affected, the FVC is also affected and the ratio is low. So هنا عندي the FEV1 is decreased, the FVC is decreased and the ratio decreased. ده كده بسميه mixed pattern. يعني there is both obstructive and restrictive feature. فهنا this is an example. لاحظوا this is the abnormal. It is a small curve and عنده scoop. It is being scooped. So this is a mixed pattern. So I hope now these are clear. The obstructive pattern, the restrictive pattern, and the mixed pattern. Now, just to summarize what we've been saying, in the FVC in if it is normal, ratio is normal, this is normal. Now, if the FVC is normal, but the ratio is low, the ratio is low. قلنا mathematically معناته البسط هو القلة. ما دام البسط هو القلة ونحن عندنا FEV1 في البسط, so this is obstructive defect. Now, if the FVC is low, but the ratio is normal, دي معناته انه both of them they decreased اللي هي the FEV1 والاف في سي. وقلنا نقصان الاف اي في 1 ما معناته انه the airways are obstructed، لا، because of the decrease of the total cross sectional area of the lung, because restrictive lung disease usually اللي هي it includes small lungs, so this indicate restrictive. اما اذا لقيت الاف في سي low والريشيو برضه low, this is a mixed pattern. So I hope now this usually will clarify a lot of misconceptions regarding the different patterns of the spirometry. So now you know the obstructive pattern or defect, the restrictive, and the mixed. Now, نجي to the most confusing points, that is, let's look at them in the flow volume loop. In the flow volume loop. بنفس الطريقة تكلمت عنها. Usually the degree of obstruction is determined by the concavity اللي هي by the scooped end. كل ما كان obstruction more severe كل ما كان this is more scooped. طيب this is number one. طيب number two، لو مذكرين قبل انه انا قلت هنا عندي الريزيديوال فوليوم وهنا عندي التي ال سي، مذكرين قبل في الفلو فوليوم لوب. Now one thing is that دائما ال obstructive lung disease انا بتكلم عن الفلو I'm talking about the flow volume loop. Usually the loop will be displaced to the left اللي هو toward higher lungs اللي هو toward the TLC. دائما هتلاحظ انه in obstructive lung disease the loop will be shifted or will be displaced toward the TLC لانه because they are breathing with higher lung. الTLC في الobstructive بيزيد. So this is regarding the 2 points in the flow volume loop. والحقيقه هي نفس الفكره بتاعت الكيرف انه بكون عندي السكوبد اند اور الكونكافيتي دي. هنا ضفنا معلومه انه the degree of obstruction اللي هي is affecting the concavity. كل ما كان الobstruction greater كل ما كان this area is more concave. الحاجه الثانيه or more scoop. الحاجه الثانيه because patient with obstructive lung disease they are breathing at higher lung volumes. بالتالي the volume or the loop will be displaced toward higher lung volumes. يعني في اتجاه التي ال سي اللي هي في الاتجاه الايسر toward the 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 left. العكس تماما في الريستريكتيف. طيب بنفس الطريقه دي كيرف اللي هو this is the curve لو قارنا بالنورمال is a miniature. The curve is a miniature and now it will be displaced toward lower lungs. فالآن it will be shifted toward the right. دائما restrictive will be shifted toward the right. دائما في restrictive بيكون عندي a steep flow like this. دي steep flow like this بيسموه the witch hat appearance. Witch hat appearance. ليه؟ لأن elasticity is high. So once the lungs are expiring, this will increase a high flow. عشان كده بيديني this high flow pattern وبسموها بيديني شكل الwitch hat appearance. So the lung volume is displayed is decreased in miniature وقلنا it is displayed toward lower lungs. So the flow volume loop it appears as a miniature of the normal curve with supranormal flow. اللي هي supranormal الفلو بيكون زايد فعشان كده بيكون بيديني الشكل ده like this. The flow is steep. ليه؟ لأن elasticity عالية. The elasticity is high. فليه زي ما قلنا this is known as the witch hat appearance. This steeping is the witch hat appearance. That is a steep flow which is secondary to the high elasticity in restrictive lung disease. This is the ما يعرف بالwitch hat appearance. Now let's talk about this point. Other uses of the flow volume loop is the detection of obstruction in the upper airways. So you can use the flow volume loop. ممكن نستخدم الفلو volume loop to detect obstruction or obstructive lesions of the upper airway. طيب أول شيء نجي نعرف ما هو ال upper airway. What is the upper airway? So upper airway is defined as the portion of the upper airway is the portion of the airway that is extending from the mouth, to the main stem bronchi. This is كله بقول عليه upper airway. This is the portion that extends from the mouth to the main stem bronchi. This is known as the upper airway. Now, the upper airway is divided at the sternal notch or at the thoracic inlet into intrathoracic upper airway and extrathoracic upper airway. Intrathoracic and extrathoracic. I will explain to you ليه الصورة دي مقلوبة in a while. So the upper airway عرفناه. قلنا this is the portion of the airway extending from the mouth to the main stem bronchi. The upper airway ذاته is divided into two portions by اللي هي at the level of the thoracic inlet اللي هي 1 to 3 centimeter above the suprasternal notch at the level of the first thoracic vertebra. بيتقسم into intrathoracic airway, extrathoracic airway. طيب نرجع. انا قلت انا بستخدم الفلو فوليوم لوب. I use the flow volume loop to detect upper airway lesions. Now these can be either fixed lesions or variable. Now variable بمعنى they differ or they change with the phase of breathing. So variable thoracic obstruction فمعناته عندي variable intrathoracic obstruction وعندي variable extrathoracic airway obstruction. فبقول عليه variable معناته it either affects expiration or inspiration. الفيكس ده ما ثابت. It affect both inspiration and expiration. طيب نجي للمعلومة بتاعت why this يعني ليه أنا عملت الكيرو ده مقلوب. باختصار what's out is in. What is out is actually in. بمعنى extrathoracic airway lesions will affect the inspiration. What is out is in. فلو عينا لللوب this is my loop. قلنا هنا expiration هنا inspiration. The out وده in. An extrathoracic airway that is out is going to affect which phase of breathing. It will affect inspiration. عشان كده انا عملت لكم الكيف ده بالقلبه. So اي حاجه هنا that is extrathoracic will actually affect the inspiratory portion of the curve. And intrathoracic airway lesions will affect the expiratory phase. ده بقول عليه انا variable intrathoracic or variable extrathoracic. So usually this obstruction appears as a squared off. This is the اسمه squared off flattening. كده الآن نيجي بالك ترم اسمه scoop داك براو. هنا ده squared off. So the portion that is affected will appear as squared off. It will become flat. Now let me talk a bit about the physiology شوية. إنه why extrathoracic lesions affect inspiration, why intrathoracic lesions affect why intrathoracic lesions affect expiration. طيب just a little bit of small physiology. Now إذا أخذنا مثال إنه this is my airways and this is the airway. قسمناه into extra thoracic وهنا intra. طيب so say for example this is my lesion. نمسك for example and extra thoracic هنا عندي lesion هنا. Say for example هنا we have a lesion in the upper airway that is extra. Say for example vocal cord paralysis, vocal cord constriction. So usually these will affect which phase? Inspiration. How or why do they affect inspiration? طيب during expiration انا هتكلم ب two pressures. هنا انا الان بتكلم عن extra thoracic. طيب هنا عندي دي tracheal pressure وعندي the atmospheric pressure. during expiration during expiration during expiration يعني انا نطلع في الهواء. كلنا عارفين في الفيزيولوجي انه دائما inside the chest بيبقى more positive. فهنا حيكون الانتراتراكيال pressure is more than the atmospheric pressure. فبالتالي يقوم بيحصل لي this will cause expansion. this will cause expansion. تمام. now I'm talking كمان منتو. انا الان بتكلم عن extra thoracic airway obstruction انه ليه it affect inspiration. طيب قلنا انا هنا this is the extra و this is intra. انا هنا عندي for example vocal cord paralysis. عندي vocal cord paralysis. اللي عشان كده دايما العيانين بتاع vocal cord paralysis بيجوا ب stridor. ليه stridor appears during inspiration؟ ليه؟ طيب قلنا normal during expiration the tracheal pressure is greater than the atmospheric pressure. بالتالي this will expand the trachea. But during inspiration بيحصل العكس. during inspiration لأن أنا محتاج الضغط داخل الصدر يبقى نيجاتيف. بالتالي the tracheal pressure now will become less than the atmospheric pressure. هيقوم يضغط الاتموسفيريك pressure على التراكية، وهي التراكية already فيها for example intratracheal tumor أو فيها vocal cord paralysis. So this will cause the stridor. So this will cause the obstruction to affect inspiration. So extrathoracic airway obstruction will cause flattening of the inspiratory portion. Will cause flattening of the inspiratory portion. يعني I hope this is clear. On the other hand لو مسكنا intrathoracic قلنا these affect the what is in now will affect out اللي هي intrathoracic will affect expiration. طيب بنفس الطريقة now this is my airways. الآن the lesion is here. My lesion is intrathoracic. Lesion is intrathoracic. Now during inspiration هنا الآن المقارنة حتكون بين منو؟ حتكون between the tracheal pressure and the pleural pressure. الآن أنا حتكلم المقارنة حتبقى بين tracheal pressure and the intrapleural pressure. During inspiration the tracheal pressure is greater than the intrapleural pressure لأنه the intrapleural pressure during inspiration هو أصلا يعني during rest هو negative. ف during inspiration بيبقى more negative. So during inspiration the intratracheal pressure is greater than the intrapleural pressure. فده بيعمل expansion to the airways. This is during inspiration. During expiration now the intratracheal pressure will become less than or lower than the intrapleural pressure. فبالتالي intrapleural pressure now will cause compression of the bronchi. This will produce the sound with expiration وكلنا بنعرفه as the wheeze. So intrathoracic airway obstruction will produce wheeze, that is during expiration, whereas extrathoracic airway obstruction will produce stridor, that is during inspiration. So إذا دي واحدة من الفوائد بتاعت الفلو فوليوم لوب إن you can detect the extra thoracic sorry it can the upper airway obstruction. فعرفنا يعني شنو upper airway وقسمناه كيف لاكسترا thoracic وانترا thoracic، وعرفنا انه كيف انا اعرف انه this is extra thoracic or intra thoracic variable ولا fixed. قلنا سميناهم variable because they vary with the phase of breathing. Extra thoracic airway obstruction will cause squared off appearance of the inspiratory portion of the curve, whereas intrathoracic airway obstruction will cause square off appearance of the expiratory portion of the flow volume loop. اما الفيكس ده سهل. الفيكس لانه it will affect both expiration and inspiration. زي مثلا التراكيال stenosis دي حيكون عندي flattening of both the inspiratory and the expiratory curve. So I hope this will clarify a lot about the flow volume loop. لكن بعد ده كله بجي وبقول إنه the flow volume loop is an insensitive test for upper airway obstruction. يعني بعد الكلام الكثير ده كله it's still an insensitive test. ليه؟ لأنه عشان ال square of appearance والحاجات اللي اتكلمت عنها دي عشان تظهر usually the tracheal lumen should be less than 8 millimeters. يعني عشان يا دوب تظهر لي الافكتس دي التراكية اليومي المفروض يكون اقل من 8 ملم or 80% reduction in the tracheal area. So it is a bit late يعني. So usually patient with late manifestations of obstruction they will have such degree of or the flow volume loop will affect it. معناته in early stages of obstruction the flow volume loop will become will be normal. So here all of this is what I've been talking about, and these are the extrathoracic. So we'll have flattening of the inspiratory curve, intrathoracic variable, patient will have wheeze, this will affect the expiratory phase. And fixed, for example, tracheal stenosis, this will have both the expiratory and inspiratory curve are flat. Now, if you remember, قبل قلت لكم the information of the FEF 50 to FIF 50 is less than 1 اللي هو هذه. So in variable intrathoracic قلنا what is out is in. طيب ما دام variable intrathoracic معناها حيتأثر لي ده. This will become flat. معناتها FEF is going to decrease. FEF is going to decrease. بالتالي الريشيو will become more even lesser than 1 أقل من ال 1 اللي هي FEF 50 مقارنة بال FIF. والعكس في الفاريبل اكسترا ثوراسيك هيجي ده هيجي للاف اي اف بالتالي الريشيو هتبقى more than 1. هنا في الفيكس they will remain the ratio will remain the same لانه both FEF and FIF both of them will be reduced عشان كده this ratio of 1 will remain the same. And these are the causes of upper airway obstruction. خدتين variable extrathoracic, variable intrathoracic and fixed. فده سميناهم variable لأنهم they differ with the phase of breathing. And I will leave it so you can go through them one more time. So these are the causes of upper airway obstruction and the use of the flow volume loop to detect these obstructions. Now we have a quick exercise and I hope you are you're not really bored or you're paying attention. So now let's quickly look at this and tell me what do you think. So curve A. So you are free to to write in the chat. What do you think? Curve A. Anybody? What do you think about curve A? Okay, so curve A, it appears normal. So curve A is a normal looking curve. So the one with the orange, this is the predicted. Your patient is the one with the blue. So it is a really good curve, good start. He reached the peak, a linear decline up to the flow. So this is a normal curve. Now let's look at B. Now, what do you think about B? Yes, Dr. Mahmoud, this is obstruction. Why obstruction? Look at the scoop. You can see it here. It is scooped. So curve B واضح جدا هنا the scoop. So this is a moderate obstruction. Now curve C. Look at it. Okay. It's also an obstruction, and it's a severe obstruction. I told you that. Look at this is the scooped end. And it is so scooped بالنسبة انه this the linear flow ده الطبيعي قارنه بينه وبين the predicted اللي هو معمول بالاورنج. So this is a severe obstruction. This is severe obstruction. Severe obstruction. Okay, curve D. A curve with normal flows لكنه smaller than D. So this is restrictive. This is moderate restriction. If you look at E, now هنا witch hat appearance. This is yes. This is the witch hat appearance. بالتحديد واضحة أكتر حاجة في E. اللي هي this is the steep flow. So this is witch hat. So E witch hat appearance. So this is clearly severe restriction. Okay, F. Okay, F. Who actually here it looks like a a fix لكن الفلاتنينج أكتر وين؟ expiratory, expiration or inspiration. So usually this is F variable extra thoracic obstruction. This is variable extra, yes, variable extra thoracic. Okay, this one. Here now the flattening is more in the expiration. So this is variable intrathoracic. So G variable intrathoracic. H اللي هو ده الواضح. This is the flattening of both. So this is flattening of both. So H, this is the fixed. H, this is the fixed. How about I? Can somebody comment on this? So I, this is an example of a weak effort. This is example of a weak effort. إنه لاحظوا للكيرف البيك expiratory flow قلنا لازم يكون it is a peak. هنا it is a bit flat and usually there is no linear decline. Okay, thank you for your contribution to this. Okay, now let's come to the last point. That is the interpretation. I will give you a stepwise approach how to interpret your PFT. Now, this is where we bring it all together. So in the spirometry with the volumes, how do we usually read the PFT, or how do we interpret it in order to reach a diagnosis, or at least to have some differential? So many organizations like the National Asthma Education Prevention Program, the GOLD, the ATS, all of these, they recommend to do PFT. So you need to have a stepwise approach, not only to interpret the PFT from office or the pulmonary function lab, but also determine what test that you need, you furtherly need to run, and how to use the PFT result to formulate differential diagnosis. One article, one of its recommendation, that is by the American Academy of Allergy and Asthma and Immunology, they say that usually one of their recommendation to not diagnose or manage asthma without spirometry. This is one of their recommendation. You should not diagnose or manage patients with asthma without doing with spirometry. And from the same article here, there is no difference. They found that there is no difference between PFT measurements obtained in the office and those obtained in the pulmonary function lab, as long as a trained personnel calibrate, administer, and interpret the result. So therefore, last time, now you should have you have a good knowledge about how to perform a correct spirometry technique, and now I will give you the knowledge to how to interpret. And again, I encourage you all to have this spirometry at least in your clinic, to do it as when you can. So it is the same, and I think in the spirometry is the same for echo for the cardiologist. The PFT or the spirometry is indispensable for the pulmonologist. زي echo هو لا غنى عنه للكارديولوجيست. So we should attempt to have this idea انه تاني يكون اي شخص عندنا his own spirometry in his clinic. Why not? Even in the referred clinic, especially with those patients with asthma. And especially now, after I hope I delivered the basic or simple information on how to do to perform a correct technique and how to interpret them correctly. So now, what are the steps? These are the 8 steps. Step number 1, determine if the FEV1 FVC ratio is low. طيب أول شيء قبل الكلام ده كله, before jumping to the steps, usually you should examine. أول حاجة تتأكد إنه the flow volume loop, examine the flow. أخذ نظرة على flow volume loop. Decide whether it looks like obstructive pattern. طبعا بعد ما أتأكد إنه acceptable, repeatable. Sometimes look at the curve قبل ما نعاين numbers. Look at the curve. بدينا to pattern من الباترنز تكلمنا عنهم. Does it look like obstructive pattern بالscooping of the expiratory flow curve, أو is it restrictive اللي هي عندنا الطول narrow peak expiratory curve سميناه which had appearance. هل في variable or في fixed obstruction اللي هي بالflattening. So before you jump to these steps, أول شيء have a look at the shape of the curve. It will guide you. And sometimes without looking at the numbers, from just the curve, you will have an idea. Is it obstructive, restrictive, variable, extrathoracic, intrathoracic, fixed, whatever the cause. So now let's look at the steps. And then step 1, determine if the FEV1 FVC ratio is low. Now, here physicians, here 2 options to determine the ratio is low. The first option is to use the gold. The first option is to use the gold. Luminous gold بيستخدم ال cutoff point less than 70% ratio. Or the second option is to follow the ATS criteria. وزي ما قلت لكم قبل الناس ال ATS criteria بيستخدموا the lower limit of normal as a cutoff. So most of us we are familiar with the goal. So determine the first step is an أول خطوة كده. نحن الآن عرفنا this spirometry curve with different patterns. الآن عايزين نركز على إنه أنا الآن عندي PFT report. أنا عايز to interpret it عشان to have to build up a differential or to reach a diagnosis. طيب أو أحدد إنه what step to do next إذا ما وصلت لdiagnosis معين. طيب أول خطوة إنه determine if the ratio is low. قلنا عندنا 2 options, either using the gold اللي هم الكت بتاعهم less than 70 أو ال ATS guide criteria اللي بيستخدموا lower limit of normal. Then the next step, determine if the FVC is low. بعد الريشيو بنتقل إلى ال FVC. طيب then step 3 confirm. أنا هتكلم عن الخطوات دي تاني بالتفاصيل. Step 3 confirm the restrictive pattern. Confirm the restrictive pattern اللي هي بنعاين لها ب TLC by looking at the TLC. Step 4 grade the severity. I will give you اللي هي how to grade the severity of obstructive اللي احنا عارفينها بالجولد والrestrictive how to grade the severity. Step 5, determine reversibility of the obstructive defect. Is it responding to bronchodilation or not? Step 6, bronchopropagation. طيب bronchopropagation ده إذا أنا ما عندي clear reversibility or bronchodilator response فبقوم بعمل exercise chilling or الميثاكولين chilling. These are bronchopropagation. Then step 7, at this point you should have a differential diagnosis, and the last step is to compare the current and prior PFT results. طيب however هنا في نقطة مهمة. طبعا the comparison if available يعني if the patient can in the system of the hospital بيكون مديك the previous visits, you can compare between the previous and the current. لكن هنا هتخط معلومة مهمة انه زي ما قلنا last time the FVC and FEV1 they decline 20 to 30 mL per year. يعني ممكن المريض يكون جاي قبل 5 سنين، انا هتوقع انه في كل سنه انا the FVC and FE1 it declines by 20 to 30 ml per year. So you should put this in your in your mind. So this is the ATS versus the gold. طبعا هنا most of us we are very familiar with the gold criteria. طيب اللي هي الجولد ودي اللي هي دي severity انه mild more than 8 moderate اللي هي 50 and less than 80. طبعا هنا في الجولد ما عندنا moderately severe لكن دي موجوده في الاي تي اس انه moderately severe. ذاك الفيري السيفير في الجولد 30 less than 50 more than 30 less than 50 والفيري سيفير في الجولد less than 30. So I'll give it to you here, you can revise them later. So these are the ATS guidelines and the gold guidelines. Now نيجي to this point I would and I wish all you to focus with me. نيجي هنطبق الآن all of these steps. طيب in each step by one أنا اديتهم الآن الثمانية. طيب now let's look at them. So now قلنا what's the first step? Determine if the ratio is low. The ratio if it is low. So this is step number 1. طيب هنا هيكون عندي two sides. هنا obstructive pathway وعندي restrictive pathway. طيب نمسك أول حاجة ال obstructive pathway اللي دي إذا كانت الريشيو مالها low إذا هنا حيكون عندي دي obstructive pathway. So this is the obstructive pathway. إذا قلنا what is the first step in interpreting the PFT? Look at the ratio. If the ratio is low كده أنا ماشي في اتجاه منه الobstructive. الخطوة الجاية قلنا شنو في الستبس بعد if the ratio is low look at the FVC. So الخطوة الأولى قلنا عينا الريشيو the ratio is low look at the FVC. هنا عندي خيارين أما يا إما ال FVC تكون normal or high أو ال FVC تكون low. لو كانت ال FVC normal or high ده بيبقى لي طوالي straight forward this is obstructive lung disease. طيب تاني من البداية look at the ratio first step. If the ratio is low كده أنا ماشي في الاتجاه بتاع the obstructive pathway. قلنا الخطوة الثانية شنو؟ look at the FVC. Now if the FVC is normal or high دي كده ادتني كل الخصائص بتاعت منه obstructive lung disease. So this is obstructive lung disease. Now if the FVC is low الخطوة اللي بعديها شنو؟ determine the restriction. كده انا خلاص ده بيجي ماشي لي على mixed. هقوم اعاين دي step number 2. هنا step number 3 I will look at the TLC اللي هو ده اللي هيحدد لي في restriction ولا لا. So هنا عندي 3 خيارات either انه يكون low. So if the TLC is low الان عندي الريشيو low والFVC low والTLC لو طلع low ده طوالي هيبقى لي mixed. This is going to be mixed. So I hope you are with me in this. So قلنا look at the ratio. If the ratio is low, this is the obstructive pathway. This is the first step. Then look at the FVC. If the FVC is normal or high, this is obstruction. دي كده خلاص دي سهلة. طيب إذا طلعت ال FVC هي ذات اللو كده أنا ماشي في الاتجاه بتاع الريستريكشن. Then أنا to determine the degree of restriction I will look at the TLC. Now if the TLC is low معناته أنا عندي TLC low معناته the restriction والFVC والratio برضه low ده معناته obstruction معناته this is mixed. So both low this is mixed. طيب نجي للخيارين الثانيات. إذا طلع لي high what does this mean؟ يعني أنا عندي الريشيو low والFVC low. التوتال lung capacity طلعت high. The total lung capacity now is high. So this is obstruction وما أي obstruction plus hyperinflation. لأنه TLC high. The TLC is high معناته this patient is breathing with larger volumes وعنده features بتاعت obstructive والFVC low والTLC high. This is obstruction with hyperinflation. Obstruction with hyperinflation. طيب الخيار الثالث إذا طلع TLC normal. This is going to be obstruction. This is obstruction plus air trapping. ما هو TLC normal وفي obstruction معناته for example this is obstruction with air trapping. فكده الآن أنا بقى عندي هذه الفكرة بتاعت establishing a differential diagnosis. Establishing the differential diagnosis. So now اللي نحن الآن ماشيين بالخطوات. Step 1 look at the ratio. If it is low معناتها أنا حنتقل إلى the obstructive pathway. طيب الخطوة اللي بعديها بعين ال FVC. إذا لقيت ال FVC low دي معناتها ماشي لي كده في اتجاه ال restrictive. فقوم الخطوة اللي بعديها 3 determine the restriction بالTLC. If the total lung capacity is low دي بتبقى mixed both obstructive and restrictive. ليه؟ لأنها restrictive ماخذ اللو TLC obstructive لأنها ماخذ اللو ratio. طيب نجي نعاين للTLC. إذا الTLC طلع normal لكن في obstruction. So there is an obstruction but the total lung capacity is normal. معناته this is air trapping. Obstruction with air trapping. For example like in asthma. طيب if there is obstruction with high TLC, now this is obstruction with hyperinflation and this goes with for example emphysema. This goes with emphysema. طيب هل حجيب على كده اللي what do you need to do next؟ اللي هي قلنا الخطوة الرابعة the fourth step is grading the severity. Grade the severity ومعاها bronchodilator response. So خطوة 4 وخطوة 5 for these للثلاثة ديل what you are going to do is to grade the severity and the bronchodilator response. طيب after that you can do further testing like we can do for example we can do the DELCO. طيب من الدلكو if the DELCO is high or normal, if high or normal this goes with asthma. يعني بعد الكلام ده obstructive with air trapping or obstructive with hyperinflation with a high or normal DELCO this usually goes with asthma. If these يعني obstructive with air trapping feature or obstructive with hyperinflation with a low DELCO this goes with emphysema. This goes with emphysema. So this is كده بالنسبة للobstructive pathway. إذا الآن عملنا الستبس وفي النهاية طلعنا بإيه؟ بديفرنشيال diagnosis. So is it clear so far? So I just need you to say yes or no in the chat so I can proceed to the next restrictive pathway. So is it clear for all? excellent. So now بنفس الطريقة we will move to the restrictive pathway اللي هي حنتجه الآن إلى اليسار. Now we move to the restrictive pathway. إذا نفس الخطوات قلنا الخطوة الأولى look at the ratio. طيب عرفنا إنها لو كده معناتها حمشي في الجهة دي obstructive pathway. طيب نجي الآن لل FEV1 FVC ratio. Now either it is normal or high. ده كده حخش في restrictive pathway. This is now the restrictive pathway. بنفس الطريقة الخطوة الثانية شنو بعد ال FE1 FVC هعاين إلى ال FVC. Look at the FVC. So step number 2 برضو هنا زي دي. Look at the FVC. Now if the FVC is normal, if the FVC is normal يعني ratio normal or slightly high. Well, FVC is normal. This is a normal spirometry. This is normal. أما إذا جات ال FVC low, if the FVC now is low, أنا عندي الريشيو normal or high. ال FVC low قبل أنا قلت إنه the FVC determined is affected by the lung parenchyma معناته أنا عندي some sort of restriction. الخطوة الثالثة شنو؟ بعاين ليه طوال ال TLC هو اللي بوريني في restriction ولا لا. Look at the TLC. So if the TLC is low طوال TLC is low كده معناته عندي restriction. This is restriction. So this is parenchymal restriction. طيب إذا TLC يعني normal أنا عندي البيشنت ده الريشيو بتاعه normal or high لكن ال FVC بتاعه low. The FVC is low حاجة ماشية مع restriction لكن ال TLC is normal فده بقول عليه أنا this is known as a non-specific pattern. This is a non-specific pattern. إذا أنا عندي obstructive واضح جدا restrictive واضح جدا وعندي mixed وواحد فيما بين اللي هو non-specific pattern. ده إنه البيشنت بيكون الريشيو بتاعه normal or high والتي ال سي بتاعه normal لكن ال FVC هو الحاجة الوحيدة الناقصة. The FVC is low. The FVC is low. طيب so what you are going to do for this non-specific pattern? Usually you need to check for airway resistance اللي بنعمل الرو. You need to check for the airway resistance. You need to check for airway resistance. إذا لقينا ال airway resistance low, if the airway resistance is low or normal, so usually this is due to chest wall limitation. Chest wall limitation. يعني أنا عندنا specific pattern بسبب ال FVC is low. عملت ال airway resistance وطلعت لي low or normal. So this is chest wall limitation. طيب chest wall limitation قاسم بها شنو؟ including obesity ممكن تكون muscle weakness or poor test performance. ممكن يكون poor test performance. أما إذا عملت ال airway resistance وطلع لي high طوالي ده حيتحول من non specific حيبقى obstructive لأن عارفين إحنا في الobstruction the airway resistance will increase. إذا أنا تحولت من non specific pattern بال airway resistance اللي هي الرو مشيت إذا بقت high this is obstructive. اوكي so هل حنجيب على كده؟ لسه عندنا further test اللي هو منو is the delco. it is the delco. أنا عندي restrictive هعمل الدلكو. إذا الدلكو طلع normal if the delco is normal يعني أنا عندي restrictive picture اللي هي ratio normal ال force vital capacity low ال TLC is low الدلكو is normal so this is an extra pulmonary restriction due to chest wall limitation اللي اتكلمنا عنها obesity, muscle weakness, kyphoscoliosis. These will cause restrictive lung disease. يعني the lungs اللي will be prevented from expanding and relaxing normally. لكن there is no problem with the gas exchange. So a restrictive pattern with normal delco, this goes with extra pulmonary restriction. طيب الآن عندي restrictive picture with الدلكو طلع لي low. دي طوالي will go with pulmonary or parenchymal restriction. يعني مثلا patient عنده asbestosis, IBF اللي هو كل interstitial lung disease. These will cause restrictive picture with low delco. طيب انا ممكن patient يجيني normal اللي هي اذا بريت this pathway normal FVC. اذا انا عملت للبيشنت ده الدلكو برضو عندي two possibilities. الدلكو ممكن يجيني normal which is this is normal. يعني انا عندي normal والدلكو normal دي طوالي normal. لكن النورمال spirometry with decreased delco, what is the cause? Usually the cause ممكن يكون parenchymal or vascular. يعني مثلا parenchymal like early stages of interstitial lung disease. early stages of interstitial lung disease اللي هي عشان كده you will بيقول انه الدلكو is very sensitive to detect the changes in interstitial lung disease اكتر من السبيرومتري. So in the early stages of interstitial lung disease, the first pulmonary function test that change is the DELCO. فممكن البيشنت يكون the patient يكون عنده normal spirometry with the DELCO is decreased. So this is interstitial lung disease. أو ممكن vascular like pulmonary hypertension. Pulmonary hypertension. Pulmonary it may be pulmonary hypertension. So اللي هي this is كده the stepwise approach in how to interpret the PFT اللي هم spirometry with the lung volumes لحد ما وصلنا at the end يكون عندنا differential diagnosis. اللي this is what I've been talking about إنه what is the difference between restrictive air trapping, hyperinflation, neuromuscular weakness as an example of extrapulmonary restriction. So simply let's just fill this table. Let's look at this table and fill it. دي برضه will summarize what I've been saying. So for example, in restrictive diseases, in pulmonary restrictive diseases, the FRC, the functional residual capacity, is going to will decrease. Yes, the FRC will decrease. Residual volume will also be decreased. Yes, the residual volume will be decreased. What about the vital capacity? The vital capacity will also proportionally be reduced. بالتالي, since all of these are reduced, the TLC will be reduced. So these are the lung volumes in case of pulmonary restriction. Now let's look at obstructive. طيب عندنا two types of obstructive اللي either في air trapping or hyperinflation. Now obstructive, when there is air trapping, what will happen to the FRC? Functional residual capacity in air trapping. So air trapping معناته residual volume is increased. So والresidual volume هو جزء من ال FRC. So it is going to be increased. So FRC will be increased. Already أنا قلت the residual volume will increase. How about the vital capacity in air trapping? Since both of these two will increase, on the expense on the vital capacity, so the vital capacity is going to decrease. The vital capacity is going to decrease. الآن عندي ال FRC increased والvital capacity decreased. عشان كده total lung capacity will remain unchanged. The TLC will remain unchanged. عشان كده قبل yes normal. عشان كده قبل قلنا إذا TLC normal, this goes with air trapping. Now let's move to the next. That is obstructive with hyperinflation. Yes, FRC is going to, sorry, the FRC is going to increase. FRC, yes, is going to increase. How about residual volume? Hyperinflation, the residual volume is also going to increase. What about the vital capacity? Now, in hyperinflation, لأنه TLC is also going to increase, فده حيكون برضه بالتناسب. This is proportional. So the vital capacity will remain unchanged. This is in hyperinflation. This is in hyperinflation. And the last point is extrapulmonary restrictive. Extrapulmonary restrictive. طيب اللي هو for example the chest wall limitation. So in this case, FRC will remain unchanged. The FRC will remain unchanged. But this is لأنه this will affect the movement or the relaxation of the lungs. So the residual volume is going to increase in expense of the vital capacity, and the TLC is going to decrease. The TLC is going to decrease. So this is the interpretation of the pulmonary or the lung volumes into these restrictive and obstructive due to air trapping, hyperinflation, or extrapulmonary. And this is just another summarization of what I've written in the previous slide. Here, you will see the degrading of severity. I've talked about either due to the GOLD, this is the GOLD criteria, or the ATS, and this is for the restriction. So I think this here we came to our end of the second session, that is in interpreting the pulmonary function test, that is spirometry, with the lung volumes. So what is next? And if you wish, in the third session, we'll go beyond spirometry now. We've almost covered most of the basic things about spirometry. In some next sessions, we'll be talking about the lung volume measurements. We'll talk about the gas dilution techniques and plethysmography, the DELCO, diffusion capacity, the reversibility, the bronchodilator response, and the propagation test. We'll talk about the respiratory muscle strength test, MIP, MAP, the fraction of inhaled nitric oxide and IS. So these are all حتلاقوكم في الكتاب. يعني واحدة من الحاجات اللي لاقتني في اوكسفورد يعني فينو. What is فينو؟ بالذات في الأزمة. So at least you should have an idea انه what is فينو، علاقته شنو انه in the follow up of أزمة. So إن شاء الله ده we're going just as a small sketch of each of these tests. So now it is the point of the question and answers. So if anybody is having any question, you can drop a question in the chat or the Q and A in the Q&A section.